Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 390 of our pharmacotherapy series, which majors in seizure disorders. The next clinical case reads, GOR is a 53-year-old man with partial onset epilepsy characterized by occasional tonic-clonic seizures. He has taken phenytoin for the past 2 years. His dosage of phenytoin was recently reduced from 400 to 360 mg per day because of symptoms of antiepileptic drug intoxication, that is mild confusion, occasional diplopia, ataxia, and lateral gaze nystagmus. After the dose reduction, his confusion and diplopia decreased significantly. The neurologic evaluation at the lower dose was within normal limits. No seizures occurred during the subsequent 8 weeks. He continued to complain of being mildly unsteady on his feet. He also exhibits mild to moderate gingival hypoplasia and significant halitosis. I would like you to discuss phenytoin-related gingival hypoplasia and management techniques that may be helpful for GOR. Because GOR's seizures are apparently under complete control, is there any problem maintaining him on his current dose of phenytoin? Let's look at gingival hypoplasia. Gum hypoplasia related to phenytoin is common and troublesome. Prevalence is estimated at 40% to 50% of treated patients. Prevalence and incidence rates, however, are misleading because the occurrence and severity of hypoplasia are related to the dose and serum concentration of phenytoin. Gingival hypoplasia is of obvious cosmetic importance. Also, as in GOR, formation of pockets of tissue leads to difficulties with oral hygiene, and halitosis may result. The mechanism of phenytoin-induced gingival hypoplasia is not well understood. The drug is excreted in saliva, and saliva phenytoin concentrations and hypoplasia are correlated. However, this correlation may simply reflect higher serum concentrations producing a greater pharmacologic effect. Phenytoin may stimulate gingival mast cells to release heparin and other mediators that may encourage synthesis of excessive amounts of new connective tissue by fibroblasts. Local irritation caused by dental plaque and food particles may further stimulate this process. 3 approaches to the treatment of existing hypoplasia are: A. Dosage reduction or replacement of phenytoin with an alternative anti-epileptic drug, if possible, which will permit partial or complete reversal of hypoplasia. B. Surgical gingivectomy, which will correct the problem temporarily, but hypoplasia eventually recurs. And C. Periodontal treatment, which will eliminate local irritants and maintains oral hygiene. Treatment for existing hyperplasia and prevention of further tissue enlargement is important. Assuming that phenytoin is producing adequate seizure control, a combination of gingivectomy and follow-up periodontal treatment may be the best approach. Oral hygiene programs appear to reduce the degree and severity of gingival hypoplasia when they are initiated before phenytoin therapy is started. Patients who are beginning phenytoin therapy should be educated about the role of oral hygiene in diminishing this side effect. The use of dental floss, gum stimulators, and water flossing appliances may be beneficial adjuncts to other oral hygiene techniques. Next we will look at neurotoxicity. Patients chronically maintained on intoxicating doses of phenytoin appear to be at risk for developing irreversible cerebellar damage and/or peripheral neuropathy. Cerebellar degeneration, resulting in symptoms such as dysarthria, ataxic gait, intention tremor, and muscular hypertonia, is of particular concern. This complication has been observed after episodes of acute phenytoin intoxication. Generalized seizures also can cause cerebellar degeneration secondary to hypoxia. For this reason, the relative importance of phenytoin in the development of this condition is controversial. Nevertheless, cerebellar degeneration has been reported in several patients without hypoxic seizures. Symptomatic phenytoin-related peripheral neuropathy is rare, although electrophysiologic evidence of impaired neuronal conduction is found in many patients. Symptomatic patients may complain of paresthesias, muscle weakness, and occasional muscle wasting. Knee and ankle tendon reflexes are absent in 18% of patients on long-term phenytoin therapy. The upper limbs are rarely affected. Although areflexia may be irreversible, electrophysiologic abnormalities may be closely related to excessive serum phenytoin concentrations and are reversible after dosage reduction or discontinuation. In GOR, the general discomfort of mild phenytoin intoxication and the potential for producing cerebellar degeneration necessitate a therapy alteration. The phenytoin dose should be reduced to 330 mg per day, because it may produce adequate seizure control without toxic symptoms. Should seizures recur at this lower dosage, it may be advisable to consider an alternative anti-epileptic drug. We will briefly discuss anti-epileptic drug impact on bone. Some anti-epileptic drugs have a negative impact on bone density. People with epilepsy treated with these drugs are at increased risk for bone disorders and fractures. Longer duration of anti-epileptic drug therapy and exposure to multiple anti-epileptic drugs are thought to predict bone loss. Enzyme-inducing anti-epileptic drugs, that is carbamazepine, phenytoin, and phenobarbital, have been associated with bone loss and an increased risk for fracture. Valproate, although not an enzyme inducer, is associated with decreased bone mineral density in children. Less is known about the impact of newer anti-epileptic drugs on bone mineral metabolism. Because of the length of phenytoin use, GOR is at risk. His bone health should be further evaluated by a DEXA scan to examine his bone mineral density. GOR should be evaluated for other risk factors of reduced bone health, e.g., immobility, poor diet, or family history. Oral calcium and vitamin D supplementation should be implemented. Depending on the outcome of evaluation, a change from phenytoin to an anti-epileptic drug with less or no effect on bone should be considered. The next clinical case reads, KJR, a 74-year-old man with newly diagnosed partial seizures, is referred to the neurology clinic for evaluation and treatment. The etiology of his new onset seizures is presumed to be a recent cerebral infarction. His seizures are complex partial seizures. He blacks out and loses track of time. He has no history of secondarily generalized tonic-clonic convulsions. He has had 3 seizures in the last 4 weeks. His last seizure resulted in a fall down a flight of stairs. His wife reports that he is more likely to have a seizure if he gets overtired or stressed out. He is also being treated for hypertension and diabetes mellitus. So my question to you reads: what options are available for the treatment of KJR's epilepsy? There are relatively few head-to-head comparative studies of anti-epileptic drugs in patients with epilepsy. Even fewer studies address the comparative efficacy of anti-epileptic drugs in elderly patients. 3 studies, in particular, are important when discussing anti-epileptic drug treatment in elderly persons with epilepsy. Brody and colleagues compared lamotrigine, N equals 102, with carbamazepine, N equals 48, in elderly patients with newly diagnosed epilepsy via a double-blind, randomized, parallel study. Discontinuation rates because of adverse effects, the primary outcome parameter, were higher for carbamazepine, that is 42%, than for lamotrigine, that is 18%. Using time to first seizure as a measure of efficacy, no differences were found between the 2 anti-epileptic drugs, and the authors suggested that lamotrigine is acceptable as initial treatment in elderly patients with newly diagnosed epilepsy. Carbamazepine, dosed at 600 mg per day, gabapentin, dosed at 1,500 mg per day, and lamotrigine, dosed at 150 mg per day, were compared for efficacy and tolerability in 593 patients older than 55 years of age, mean age, 72 years, with newly diagnosed epilepsy. Although efficacy was similar in all 3 groups, study termination for adverse events varied between treatment groups. Carbamazepine had the highest termination rate, that is 31%, followed by gabapentin, that is 21.6%, and then lamotrigine, that is 12.1%, with a p-value equal to 0.001. The authors concluded that lamotrigine and gabapentin should be considered as initial therapy for new-onset seizures in older patients with epilepsy. Werhan and colleagues evaluated carbamazepine, i.e. the controlled-release form, lamotrigine, and levetiracetam in 359 patients 60 years of age and older, mean age, 71.4 years, with newly diagnosed partial epilepsy via a double-blind, randomized, multi-center trial. As with the other 2 studies, efficacy, as measured by seizure freedom rates, did not differ between the 3 drugs. But retention rate at week 58, primary outcome, was significantly higher for levetiracetam, that is 61.5%, than for carbamazepine, that is 45.8%, with a p-value of 0.02. The retention rate for lamotrigine, that is 55.6%, was close to that of levetiracetam. These studies in elderly patients with new-onset epilepsy suggest that gabapentin, lamotrigine or levetiracetam would be good choices for initial treatment of KJR's epilepsy. It is noteworthy that none of these anti-epileptic drugs are FDA approved for newly diagnosed epilepsy. It is also important to consider drug interaction profile, dosing frequency, and drug costs when selecting anti-epileptic drug therapy. Generally, elderly persons take more medicines than younger individuals. For example, the average number of concomitant medications in the study by Rowan and colleagues was 7. KJR is likely to be taking other medicines for diabetes and hypertension. Gabapentin, lamotrigine, nor levetiracetam causes drug-drug interactions, although lamotrigine is influenced more so than gabapentin or levetiracetam by other medicines. Doses of gabapentin and levetiracetam have to be adjusted for renal function. Let's now consider adverse effects. Comparative studies identified minimal differences in efficacy. Newer anti-epileptic drugs, however, showed better tolerability than the older anti-epileptic drugs. In general, elderly patients not only respond to anti-epileptic drugs at lower doses and concentrations, but they also exhibit toxicity symptoms at lower doses than do younger patients. Age-related declines in renal and hepatic function may account for those observations. The pharmacokinetics of many anti-epileptic drugs have been studied in the elderly, and a decrease in clearance is noted as compared with the young. Decreased clearance of anti-epileptic drugs in the elderly has often been cited as a reason for their increased responsiveness to these drugs. The impact of anti-epileptic drugs on cognition is an important issue for all patients with epilepsy, and perhaps it is an even greater issue in elderly patients. As evidenced from the study by Rowan and colleagues, CNS toxicities such as dizziness, unsteady gait, and ataxia are common adverse effects of anti-epileptic drugs in elderly patients. These symptoms may increase the risk of falls, which are of particular concern in light of the potential negative effects of anti-epileptic drugs on bone mineral density. KJR and his family should be informed about the benefits and risks associated with each anti-epileptic drug, and they should also be incorporated into the decision-making process. Anti-epileptic drug therapy in the elderly should follow the "start low and go slow" adage, and elderly patients should be monitored for both efficacy, via a seizure calendar, and toxicity, reporting any intolerable side effects. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 391.